Hi, everyone. I am Rachel Werner, the Executive Director of Penn's Leonard Davis Institute of Health Economics. Welcome to today's seminar, Is Medicare Advantage Working? There's a lot of interest in answering that question, and we had more than 1,000 of you register for today's seminar. So it's great to have you all here. If you have questions during today's conversation, you can use the Q&A function at the bottom of your screen to submit questions. We also got hundreds of questions in advance of today's seminar. So as you can imagine, we won't get to all of those questions, but we will do our best to incorporate as many of them as we can in today's conversation. So I want to start with just a few facts and baseline information about Medicare Advantage. So Medicare Advantage was established with a promise of expanding beneficiary choice, enhancing efficiency, and driving innovation. By allowing private insurance plans to provide care for enrollees, the hope was that innovation and competition would improve the administration of health benefits for seniors. Now, decades later, more than half of eligible Medicare beneficiaries are enrolled in MA. Enrollees are often attracted by perks not available in traditional Medicare, like zero premium plans, out-of-pocket maximums, and extra benefits like dental and vision care and gym memberships. While MA offers enrollees the promise of lower cost care, some report frustration with utilization management tools, such as limited networks and prior authorization, and questions about the value of MA linger. MedPAC estimated in 2025 that federal government would spend $84 billion more on MA enrollees than if those same enrollees were enrolled in traditional fee-for-service plans. So this begs the question about the value that we are getting out of Medicare Advantage. Calls for reform of MA are also commonplace now, and some reform is underway. Our experts today will weigh in on what's needed to create a sustainable, affordable Medicare program for taxpayers and beneficiaries. And so I want to introduce our two panelists. First, Cheryl Danberg is a distinguished chair in healthcare payment policy and is principal senior economist at RAND. She currently serves on the Medicare Payment Advisory Commission as a commissioner, which advises Congress on Medicare payment policy. And also Sachin Jain, who is the CEO of the SCAN Group and the SCAN Health Plan, which is a not-for-profit MA plan. He previously served as a senior advisor to the administrator of CMS and the acting deputy director for policy and programs at the Center for Medicare and Medicaid Innovation. So thank you both so much for joining us today. I've really been looking forward to today's conversation. We invited you both here today in part because you have slightly differing ways that you think about Medicare Advantage, including the value it provides to enrollees and its role in the larger healthcare ecosystem. So I want to start with just some rapid fire questions to lay the land about where you're coming from and highlight your perspectives on MA. Cheryl, I want to start with you. So quick questions, quick answers here. What is the problem that MA is trying to solve?
Yeah, so the Medicare program was facing rising healthcare costs in a world with seemingly unlimited risk exposure in a predominantly fee-for-service payment world. And I think the idea of contracting with private plans, especially under a capitated model, it represented an alternative payment model that would limit the financial risk to the government and create incentives for plans to hold down costs below what the government would be paying them. And so the idea was lower spending while maintaining quality and access for beneficiaries. And that was the value proposition.
And where has it succeeded?
Okay, so
Just briefly.
Yeah, no, this is a big topic.
Yeah.
It's certainly tamped down on utilization of services and led to cost efficiencies such as, greater use of home health services rather than skilled nursing facilities. But I would say that the benefits from these improved efficiencies have largely accrued to private plans, and in some cases, they're shareholders and not the government. Importantly, it provided a cap on out-of-pocket spending for beneficiaries, and this was important for limiting the financial burden and especially important for low-income seniors. And lastly, it lowered the cost of coverage to beneficiaries through lower premiums, reduced cost sharing, and then the provision of these extra supplemental benefits, which I know we will talk about today. So all of these are really important to low-income seniors.
Okay. So yes, we will have a chance to dig into many of these. Third question for you before we do that. Where has it failed? You mentioned some of the failings, but other places that it's failed?
Yeah, so I think one of the key topics is really around overpayments to health plans. And, the idea was that it would save the government money, but at no point since its inception has it saved the government money. And they've never been paid less than, fee for service. And this is largely in part because of policies that actually increase payments to the MA plans above fee for service payments. And so I'll just touch briefly on a couple of these. I think the people listening in have heard people talk about favorable selection, which has increased payments to MA plans because it allows plans to bid lower than fee for service spending before producing any real efficiencies. There's the issue of coding intensity, which we've heard a lot about, and these payments that result from higher risk coding have led to higher payments to health plans. And both of these factors have led to pricing errors that cause CMS's risk adjustment system to set the payment rate too high for MA plans relative to fee for service. I would also argue that we've had big payment subsidies to MA plans in the form of quality bonus payments from the Star Ratings program. And the Star Ratings program is important because that represents new money being spent by the government each year to plans. And it also affects the benchmarks. And in many cases, they're set higher than traditional Medicare spending.
Okay. Um, so we're gonna have the remainder of the hour to talk about what needs to be fixed. So I'm gonna switch over to Sachin and ask you, I know in some places, some areas you agree with Cheryl, and some you may have a slightly different perspective. So same set of questions. What problem is MA trying to solve?
Well, I think it was originally intended to lower costs for the federal government. That was the original founding intent of Medicare Advantage. I think what it has become is a massive subsidy to low-income seniors um, in the form of richer benefits than they would otherwise get through traditional Medicare. And so I think at this point, it has to be considered an important part of the social safety net in this country. And I just want to contrast traditional Medicare a little bit with Medicare Advantage. Sometimes when you have a forum on Medicare Advantage, you don't actually talk enough about the alternative. The alternative for a low-income senior is to spend $200 on a Part B premium, 100 or so dollars on a Part D premium, and then a Medicare supplemental policy. So it's about $500 out of pocket per senior per month. Married couple, that's about $1,000 a month. The average married senior couple has an income mostly from Social Security and maybe some other savings of about $54,000 a year. So in traditional Medicare, if we're going to just go with the status quo, the program that has largely gone unchanged with a few exceptions from Congress, you're talking about $1,000 a month out of pocket. It's just out of reach for most low-income seniors. Contrast that with, what they could get. I'll just say in Southern California, there's obviously a lot of local variation. In Southern California, in Los Angeles County, you can spend your Part B premium and basically have a zero copays for primary care, zero copays for specialty care, zero copays for hospital admissions. You have a maximum out of pocket of $100 or $200 or $300, depending on the plan that you actually choose. You have a wider range of supplemental benefits that become a really important part of your life. And a lot of your medications are covered at no cost to you. And so, I think Cheryl referenced the subsidy to low income seniors, but I just wanted to make it come to life a little bit because it's really important. It's really important. And, if we were to start cutting back on MA, and as we are cutting back on MA, what's going to happen is that the benefits will get less generous, and seniors will be out of pocket a bit more. And that's the problem I think that it's solving today. But I think the original problem that we were solving was trying to give savings to the government, and in that regards, it has been a miserable failure.
Okay.
So, we can definitely agree on that.
Okay, so that's a good summary. I think that we definitely are going to have time to talk about all of these issues. So I want to just we have a lot to get through, so I'm going to sort of forge ahead here and ask you, Sachin, to talk a little bit about the growth of MA. And so you've alluded to it, but we really have seen an enormous amount of growth in MA, particularly more recently, with over half of beneficiaries currently enrolled in MA rather than in traditional fee-for-service. What's driving that growth?
Well, I think we've also taught a nation of seniors to actually start shopping. And there's been as benefits have gotten richer because of risk adjustment, and the arbitrage that a lot of plans were playing between, the cost of serving these seniors and, what Medicare would pay them from a risk adjustment perspective. The benefits got really rich. And as a result, this became a viral product. People were buying plans with Part B premium rebates. Some of them were buying plans with pickleball rackets, and so it just became a viral phenomenon. And the interesting thing is people buy Medicare Advantage plans when they're mostly healthy. They age into Medicare. They're 65. They're not thinking that hard oftentimes about the benefits and what they may need when they're sick. And I think that's also just one of the friction points for the program too, which is that I think many people have bought into the program not necessarily knowing what they're buying into. And I would say that there's a nation of brokers out there, a million plus brokers who don't make a commission on getting someone enrolled in traditional Medicare, but make a commission on Medicare Advantage. The commission, is roughly about $1,000 for a first year enrollment in California, and then there's a $500 a year renewal thereafter. So this is a big business, and the distribution channels, gain from it, and so that's an advantage that the Medicare Advantage plan has in terms of its popularity vis-a-vis traditional Medicare. It's got a whole army of people actually trying to sell these plans.
hmm So some of the growth, just to summarize, is due to the popularity of the benefits and the low out-of-pocket expenses, both in premiums and daily out-of-pocket medical costs. And then there's also, as you're saying, market factors that are driving people to MA, including brokers.
That's right. I mean, again, I think the main reason it's gone viral is it's just a better deal for seniors.
Okay.
I mentioned $1,000 a month, contrasted with Medicare Advantage plans, which are most oftentimes zero premium or a low premium, and a fully inclusive program, and it just feels like a better deal for people.
Cheryl, anything you want to add there?
I would just plus one on what Session said. And I guess where I would add is, um, you know, when he talked about people not thinking about this a lot, um, kind of one of my aha moments was when I did a seminar here at RAND for people who are getting close to retirement. And I think most people, as they age into Medicare, think they've paid for it fully through their payroll taxes. And they don't really understand that there's two parts to the Medicare program, that there's traditional Medicare and there's Medicare Advantage, and what the implications of those two choices are. And as Sasha noted, there's heavy marketing that goes on. And that's what they generally see is, the array of Medicare Advantage plans. And there's sort of no discussion of traditional Medicare as an option. But I agree. I think the key driver here has been lower cost and additional benefits.
Okay. And so I do want to dig a little bit more into those supplemental benefits and those cost sharing pieces. And maybe Sachin, I'll go back to you and ask you what you see the value of those pieces are.
Well, look, traditional Medicare has lots of holes, and I think what MA plans often try to do is fill those holes. Specific holes I'm referencing are things like dental coverage, vision coverage, major concerns for older adults as they progress in their lives that are largely unaddressed in the traditional Medicare program that MA plans try to provide support for. There's also things like transportation benefits that bring seniors to and from their medical appointments as they need that kind of service. There's gym benefits to keep people healthy and active and independent. There's oftentimes food benefits that are incorporated into plans, or an over-the-counter benefit that would allow them to go to a local pharmacy or retail store and actually buy, needed supplies. So again, I think what ends up happening is, seniors are seeing all of these different offerings within their MA plans and feel like they're getting a really good deal. Now, the dirty little secret of Medicare Advantage is that these supplements are priced or offered in a way expecting low utilization, and so they're in the programs, but many plans are not that interested in having their beneficiaries using them, and so they actually create barriers to actually accessing them. My favorite kind of high profile example of that is an MA plan that offered a pesticide benefit, but then required a doctor's note to actually have extermination services provided in your home. Who's going to go to their doctor for extermination? So I think they probably had exterminated 2 or 3 people's homes that year, is what I understand. And so again, I think that's one of the challenges is these things sometimes look good on paper, but are actually far from good in practice. And look, this has been a has been big profitable business for a lot of companies for a number of years. The big national companies have historically targeted 5% margins. And so again, I think there's the skimping that goes on that I think we have to be worried about as a country when seniors are electing into Medicare Advantage, and they think they're getting a certain benefit package, but a lot of those things are placed far out of reach or made difficult to access.
Hmm. Cheryl, I think I'd love to hear your thoughts on the supplemental benefits and what role they're playing.
Sure. So there's no doubt that the supplemental benefits offered in MA are a key attraction and that they have, as Sasha noted, kind of expanded the social safety net. But I think the mechanism by which supplemental benefits have come into existence, it's sort of a backdoor approach to benefit expansion, if you will. And, we as a country have not had an explicit policy debate or a legislative mandate to expand the MA program and to identify a method for financing those benefits. And instead, we use this thing that we're going to talk about, which is called rebates, that only exist in MA, to finance the ability of the plans to offer these benefits. And those rebates are paid for by taxpayers and by Medicare fee-for-service beneficiaries who don't, accrue those same benefits on the fee-for-service side. And so this really creates inequities between the two programs, and it distorts market competition between the two plan types. And then I think, and this sort of speaks to the point Sachin was just making, there's a lack of transparency on the use of these benefits and whether they're delivering value to the beneficiary. And CMS is, requiring as of January 1st of this year that the Medicare Advantage organizations send mid-year notifications to beneficiaries to refer to the unused benefits. But I think even with that, kind of the challenge with these benefits is oftentimes it's like one dental cleaning with a dentist who isn't, say, your regular dentist. And so I think sort of a better strategy if we're going to offer these types of benefits is to do something that looks a little more like a flexible savings account where you would, have a set of dollars deposited in the account, and then the beneficiary could determine where they want to spend those dollars. So it creates flexibility. It allows them to have continuity of care with their regular providers, and you could restrict the types of use cases against which they could spend those dollars.
So can I just ask to dig in a little bit more to some of the inequities that you're describing? So on one hand, MA, because of its potential zero premiums and low out-of-pocket costs, provides a safety net for people that otherwise might not exist because traditional Medicare doesn't is high cost to people, and unaffordable to many to cover the uncovered part of Medicare. On the other hand, you've raised concerns that the existence of these benefits also create inequities, and people get access to the supplemental benefits, which are only available in MA and not in traditional Medicare. And so I'm wondering, like, sort of what the fix is here. And either one of you to weigh in. And I don't know, Sachin, if you agree with Cheryl's point on this, but I'd love to hear a little bit more
I
about
do. I guess where I fall, come down on this is a little bit pragmatically, like, some people forget that we didn't have Part D until 2000, 2004, right? So, the issue is if Medicare wasn't providing prescription drug coverage until 2004, deferring innovation in the traditional Medicare program to Congress is really, really inefficient. And CMMI has, had its own mixed record and challenge actually bringing any, innovations to scale. So when I think about, how do we really drive innovation in the Medicare program? MA has been, far better in a lot of ways than traditional Medicare has. It's enabled value-based payments, full delegation of risk to providers, capitated payments to groups, and the on the traditional Medicare side, we're still largely operating on a fee-for-service chassis. We're still really driving a lot of overuse of unnecessary services in an older adult population that sometimes inflicts iatrogenesis. So, I think that there's a, you know, if we trust Congress to continue to evolve and innovate the traditional Medicare program, then by all means, let's just have them introduce a dental benefit, a vision benefit. My observation is just that the current politics and the current political situation makes our best path to actually drive innovation in the Medicare program firmly Medicare Advantage. That's my view, and that's a pragmatic reality. I think there's an idealistic view, which is like, yes, we should fix the whole traditional Medicare program. To which I'll always say, good luck. I have lots of other hobbies. I'd love to do other things with my life than run an MA plan, but I still think that running an MA plan is virtuous in this kind of current environment because it does give us opportunities to serve a group of people who truly need service.
so a necessary role for MA currently under the current.
I think so. Absolutely. Again, there's many people who, the Twitterati who will say like, "Oh, let's just fix the Medicare program." I'm like, "Great, go find a courageous politician who's going to do that, and we'll all vote for that person." In the meantime, we've got to work with what we have.
Cheryl.
Ooh, that's a tough act to follow. Um, I don't disagree with what Sasha just said. Congress is slow to act and to make big policy changes. I do think that traditional Medicare needs to be shored up, to create some equivalency between the two program types. And that could include, adding an out-of-pocket cap, which might mitigate the need for Medigap coverage, as well as, adding important supplemental benefits. But I do think at the end of the day, because we have these issues called, growth in healthcare spending, fiscal problems, the Part D program was essentially an unfunded mandate. And so I think we as a society have to have a larger question about, what type of resources or how much we want to spend and where we want to spend it. I don't disagree with the idea of innovation. And, through all these additional payments to MA plans, they have been able to innovate in ways that traditional Medicare has not been able to.
Okay, well, let's move on to costs. You mentioned costs. Many people actually in the audience asked about the fundamental tension around the economics of MA. So while MA was designed to save money, MedPAC and others say that it costs more than traditional Medicare per enrollee. So I want to understand what explains the current spending differences between the two. And there's a bunch of different stuff, but we're going to get weedy here for a minute. But Cheryl, can we start with benchmarks?
Okay. So just this is kind of like a primer. So each year the plans bid, and the bids represent the amount to cover an average beneficiary. And Medicare compares the MA plans bid to a bidding target, which is called the benchmark. And that reflects the average county level fee for service spending for parts A and B. And Medicare sets the benchmark at one of four levels. It can be 95%, 100%, 107.5%, or 115% of fee-for-service projected spending for the county. And those percentages are based on how expensive the area's fee-for-service costs are. And so counties with low fee-for-service costs get a higher benchmark, and counties with a higher fee-for-service set of costs have a lower benchmark. And that benchmark is also affected by a plan's star ratings. So plans can earn double bonuses if their quality is high. So when plans bid, virtually all of them bid below the benchmark. And when they do so, they can receive this rebate, and that can range from 50% to 70%, depending on their star ratings. And so the star ratings sort of creates this sort of added incentive for plans to score highly so that they can capture more of those rebate dollars.
And so just to clarify, the rebate is the difference between the bid and the benchmark.
That's
So
correct.
75% of the difference between the bid and the benchmark.
That's right. Yeah. So, this is a high stakes game to try to accrue as much of the rebate dollars as you can, which enables you to buy down premiums, lower cost share, offer additional benefits, including those supplemental benefits. So that's sort of the fundamentals of how benchmarks work.
And so how is this process relating to the costs of MA?
So in a lot of counties, the benchmark is actually higher than what we would pay for those same people in fee for service. So there's overpayments to the plans in that space, right? And we're driving spending because we're not gaining that efficiency from the plan bidding lower in terms of the cost of caring for that person. So that differential is being paid, out of taxpayer dollars. And then we had the issues that I flagged earlier about favorable selection. So healthier people enrolling in MA. So currently the risk model is overestimating the cost of care for those people. And then we have the coding adjustments that are in play that drive payments. And the Medicare Advantage plans are incentivized to code more than in traditional fee for service.
Okay, so there's a bunch of different stuff that's going into why we think, if we believe that the federal government's paying too much for MA, or the high cost of MA, I'll just say. Sachin, do you want to expand on anything Cheryl just said? Or
Yeah, maybe I'll just double click on the star ratings because I think they're such an important part of the story. And what I'll tell you is uh, that star ratings have massively positive effects, I think, in terms of their focusing plans on quality in a way that doesn't happen in traditional Medicare. So there's an intense focus on HEDIS measures, intense focus on customer experience because the stakes are as high as Cheryl indicated. So you can earn up to a 5% bonus, and that ends up being up to 100 in the counties we operate in, 150 PMPM swing, which actually enables you to field more competitive products and pay providers more generously. So the same time, there is the risk of creating inequities. When you serve harder to serve populations and you're contracting a network, there's a strong incentive to actually not serve very hard to serve people, and do some form of medical redlining actually to boost your star ratings. And you've seen practices like that where health plans have really focused on serving particular populations, gaming the population that they serve, earning high star ratings through that gaming, and then excluding certain key populations from their plans. We've gone in the opposite direction. I'll share. We've built affinity plans for very hard to serve populations. We have an LGBTQ plus plan. We have an Asian focused product. We have this is not in the hard to serve category, but in the innovation category, we have a women's product. So I think the chassis does allow you to do a lot of interesting things that you couldn't do in traditional Medicare. Some of it is real and some of it is marketing glitz. I think, some of what needs to come from a regulatory perspective is really a push towards more real impact on patients and populations. I think the star ratings program is in need of a massive reboot because a lot of the measures are outdated. They're actually quite brittle, and you really want a 4.5 star plan to be meaningfully better than a 4 star plan, which is meaningfully better than a 3.5 star plan. And I think there's edge cases where you could argue they aren't all that different. So I do think the star ratings program is an important part of any discussion about MA.
Yeah,
Can I add to the star ratings conversation?
absolutely.
I do think it's an important program, but it certainly is driving higher payments because the star ratings adjust the plan benchmark as well as the percentage of a rebate that a plan can earn. But I think the other thing that's driving spending in MA is the fact that the star ratings represent new money each year to plans. This is not a budget neutral, pay for performance program. All of CMS's other programs are budget neutral. And so I think, as policymakers rethink this space, I think shifting to that type of model with budget neutrality would be important.
That's a interesting point. And so good discussion about the star ratings. I want to talk a little bit about risk adjustment, which we sort of glancingly went past when we were talking about the costs of
It's not
MA.
a controversial topic at all, Rachel. I mean, risk
Yeah.
adjustment is everybody believes in risk adjustment.
Yeah,
So
you may have been hoping we were not going to go here, but
no, no,
but
no,
we
no.
did
It's
get a
it's
lot.
an important topic. Yeah.
Yeah, we did get a lot of questions about risk adjustment and about the question of gaming from the audience. And risk adjustment is an important policy that was originally conceived of, and in a perfect world would create fairness to adjust plan revenue to account for the sickness of patients that they're taking care of. It may have, in some cases, morphed into more of a gaming strategy. And so maybe, Sachin, if you want to just talk a little bit about where we are right now with your thinking about risk adjustment. And then I want to get to proposals out there that might affect risk adjustment.
Yeah, I think this is one of these kind of classic policy situations where, it reminds me of kind of being a surgical medical student, and when the surgeons would kind of yell at you for cutting, too short or too long. If you cut if you are not generous enough with risk adjustment, then you have plans that don't want to take care of sick people. If you're overly generous, then you have overpayments, and so it's you can't win kind of in either way. And I think you've seen provider groups that got really sophisticated about risk adjustment, and I think we had a lost decade of value-based care because a lot of medical groups were not focusing on taking better care of patients. They were focusing on risk adjustment. So I think the introduction of V28, which was the new coding model that was introduced 3 years ago and phased in over the last 3 years, was an important change because it closed a lot of loopholes. We don't have an epidemic of kwashiorkor in this country, but if you looked at our risk adjustment data, you would think that we did. And so I think we closed some of these loopholes. Um, and in some markets, providers suffered as much as 20% as a decline in revenue because they were coding that aggressively. Uh, now, but what I will say is that if you go too far, you're going to end up in a situation where um, plans are exiting geographies. You saw Vermont, 92% of beneficiaries last year had a disruption in their MA plan. Lots of geographies where we operate, you see MA plans cutting benefits, leaving markets, all of which has a massive impact on older adults. And so, the goal is to really find a model that allows us to pay plans close to what it actually costs to administer the services. And I think CMS was a little bit asleep at the wheel on this. I mean, and no offense to anybody from CMS, I think there was a lot of pressure not to engage more seriously on this topic. But we knew 10 years ago, 15 years ago that there were medical groups whose entire business model was based on risk adjustment. And we kind of allowed that to happen. And in fact, we celebrated a lot of those groups as like these value-based care miracles. We know today that they weren't value-based care miracles, they were risk adjustment miracles. But I think, we collectively didn't necessarily put in place the enforcement mechanisms to prevent this kind of behavior. And frankly, it was actually there were a lot of just very rudimentary things that we could have been doing that we just didn't do. Looking real time at distribution of codes versus the distribution of conditions in a particular geography, and then raising your hand and asking the question, is there suddenly an epidemic of kwashiorkor in in South Florida? And there wasn't. And so again, the codes get submitted, and by the way, the plans aren't coding. It's the medical groups that are actually coding. So the plans then have to, review the coding. They have to make sure it's accurate to the best of their knowledge, but it's the doctors who are actually taking care of patients. And so, it wasn't just the plans that were complicit in this, but it was also the medical groups. And I think that you're starting to see a big reversal there. And what I'm hoping is that there's going to be a revival of the kind of value-based care that we actually saw 20 years ago, which is how do we take care of seniors in their most efficient, location, site of care? How do we actually better manage chronic disease so that patients end up in acute settings less? That's what I think you'd hope to see from really good Medicare Advantage plans. But I would say in the last decade, a lot of organizations lost their way because they were just much more focused on financial success through vehicles that they were allowed to pursue through risk adjustment.
Cheryl, do you want to add?
Sure. So I think to the original point of, risk adjustment was really designed to pay the plans and their providers fairly for the health risks that they face. I mean, that's the intent. And I think that's the right thing to do. But, we've clearly seen fairly aggressive coding, and that coding intensity varies across plans in the MA market. And, because of the link between risk adjustment and higher payments, and then in turn, higher payments mean you can offer these extra benefits and make your plan look more attractive. It creates these distortions in the market in terms of MA plans being able to compete against each other effectively. And even though CMS applies a risk adjustment, it doesn't account fully for the amount of coding intensity going on and the variation across plans and how aggressively the coding is. And MedPAC has called for tailoring the coding adjustment based on how aggressively or less aggressively plans are coding. And the idea, with this type of tiered adjustment is that it's going to apply greater pressure, downward pressure on those plans that are more aggressively coding. So I do think we have to continue to stay focused on risk adjustment because it is leading to overpayments and, creating like these perverse incentives within the system and driving higher payments. And, I do think that the implementation of the V28 risk model is helping move in the right direction, but there are other things that are going to need to be done to, continue to put downward pressure on risk coding.
Can one of you just with the V28 model, the audience may not know exactly what the is, and so some sort of high level, like a brief primer on what changed.
So Sasha, you want to take that one?
Yeah, I mean, I think they pulled out a lot of codes that were driving up costs that were not necessarily associated with costs. So, I had mentioned the question protein wasting malnutrition was one of them that was egregiously overdiagnosed. Another was hemochromatosis, and again, I think there were a number of conditions that were not truly clinically significant that had been ascribed high risk that then became the subject of a lot of screening. So people started looking for these things, even if they weren't present, even if they weren't kind of if there was no clinical reason to go looking for these things, and you just saw this kind of behavior run rampant in geographies where so-called sophisticated providers were really good at became really good at capturing these codes.
Okay, so the building on that, in January, the Trump administration or CMS released a proposal to do a number of things related to MA payment, but one of them was to provide tighter guardrails around how plans adjust for the risk of their members, and that specifically was a proposal to exclude diagnoses that were found in chart reviews, but were not connected to medical claims. So what are referred to as unlinked chart reviews. Um, are changes like that going to make a difference?
Um, I would say that that moves us in the right direction. This is going to be what I call a patchwork of fixes to try to continue to drive downward pressure. Um, so, other ideas on the table, include using 2 years of diagnostic data to make sure somebody actually has a condition that's being managed, right? Because, I have seen this in my own medical care and in my kids' medical care is, oftentimes they're coding things for conditions that aren't being treated. So I think that's really the essence here of you want to pay people properly for things that they're actively managing. So if you're somebody with a migraine and you don't take any treatment for it, should a plan get paid more for that condition, right? So I would say yes, but I do think Medicare is going to have to continue to work to update its risk model because as we all know, the conditions on the ground change. There's behavioral shifts, and the other part of the V28 is it updated the data that were used to run the model with more current data.
Okay. Anything you want to add, Sachin?
No, I think Cheryl covered it.
Okay.
Cheryl covered it. Yeah.
I want to move on to a new topic, which is how MA plans have approached managing care utilization. So, managed care models like MA use limited networks, things like utilization management strategy or prior authorization to reduce utilization. And this decreased utilization, is a trade-off that consumers usually make when they choose MA in exchange for these lower out-of-pocket costs. I wanted to have a talk with you a little bit about how these traditional managed care trade-offs are playing out in MA today. And maybe we could first talk a little bit about the approaches, either one of you, the approaches of using either limited networks, prior authorization, and your thoughts about the value of those. Sachin, do you
So
want
there, so there are certainly a lot of plans that will, kind of manage their margins by aggressively imposing utilization management. And you see this, play out every day. You see it on social media. Your doctor tells you need something, your insurance company tells you you don't need it, and you're now as a patient stuck in the middle and basically triangulated. Our approach at Scan is actually quite different. We like to delegate the risk to the providers, and we like the providers to do the UM on themselves. And I think we don't talk enough about the different kinds of UM. So the kind of UM that I just described, where the doctor prescribes something and the insurance company tells you not to use it, is something I called hard UM, which is, kind of feels a little bit brutal to patients, feels bad to doctors. In a world where you're delegating risk to providers, you have the opportunity to do soft UM, which is when the objectionable procedure doesn't get offered in the first place. And I'll share the story of my father, who was a traditional Medicare beneficiary, fee-for-service beneficiary, who every 3 months got an echo. Every 3 months got an echocardiogram. No, not with any clinical change, but he just went to his cardiologist and he got an echocardiogram. And I would say, Dad, you don't need that echocardiogram. He said, Well, I feel good about getting it. It's a harmless test. And his cardiologist wanted to just make sure that he was doing okay. There's a lot of that medical spend in traditional Medicare that is absolutely unnecessary that we don't talk enough about. in a fully delegated capitated model like the one we operate, his cardiologist would just never offer that procedure, never offer the test because there's no real clinical value to it, no real clinical benefit, and it actually uses a lot of resources. And so we think that, that our approach, fully delegating risk to providers, and what I mean by that is we get a check from the government. We give a large percentage of that to a medical group, a health system that wants to take risk, and then we help them perform under that arrangement, is far superior to the alternative, which is what a lot of health plans use in a lot of geographies, which truly does, frustrate doctors and frustrates patients. And it is one of the, kind of dirty little secrets that the reason that plans are able to offer such generous benefits is that they're skimping on payments to providers, and we think that that's wrong. So that's our approach to addressing this issue.
True.
So I think utilization management has played an important role. And I mean, you can even see in Medicare fee-for-service, the Center for Medicare and Medicaid Innovations is starting to explore applying some utilization management techniques to that side of the equation. Because, obviously spending is price times quantity. And, we're trying to reduce the quantity of what, I think Sachin and I and others in the world would say is low value care, care that doesn't confer, benefit to the patient and in some cases is harmful. Um, and, I'd say that over the past 20 years, it's been kind of rough going for the utilization management space. There have been a lot of denials of care. Some subset of the population chooses to fight those denials. We don't actually see in the data how many people really experience that problem. And in most cases, those denials are overturned. So it has created a lot of friction in the system. It's clearly led to lower utilization. I think it has created a lot of problems for consumers who don't understand this space and have a hard time evaluating what's, high value versus low value care. I would hope moving forward we could build in what I'm going to call smarter utilization management to try to tamp down on utilization.
And what does smarter utilization management look like?
You know,
Cheryl,
uh,
you don't like soft UM, Cheryl? I thought I
well,
solved the whole problem.
yeah, I was kind of intrigued with that. It'll be interesting over the next decade to see how AI, plays out in this space. I, am still a neophyte in the AI space. But I mean, clearly it's going to be applied on, the plan side to try to tamp down on unnecessary use of services. And so the question is that going to lead to, more utilization being denied and more problems, or will it be able to, be better tailored based on, additional clinical information or other information that can be brought to bear?
Yeah, I don't know, Sachin, if you know anything about this. I have seen research showing that it's already being used for prior authorization, particularly in transfer to request for post-acute care, and that the denial rates have just gone up a huge amount. Whether they're appropriate or not, I couldn't tell you.
Yeah, and that's why I think it needs to kind of get out of the hands of bean counters who sit far away from patient care. I view this as a clinician. I view this as patient, family member of patients, and you really want the medical infrastructure to be able to do what it thinks it needs to do, independent of the review of some stranger sitting in their shorts in a call center somewhere telling you that you can or cannot administer a procedure. I heard a crazy story from one of the big, from a big health system, cardiologist, trained at Penn actually, Rachel, and he basically was told that he was allowed like a 1.5 day length of stay for a patient post STEMI from a big national plan. And he texted me, he said, what is a point 0.5 day? And like, why are they telling me this? It's a STEMI. The patient needs to stay, and I'd like to watch the patient for a few days. And, rather than just being able to take care of the patient, he's like, churning and dealing with an insurance company, dealing with a bureaucrat sitting somewhere else who's going to overturn it once he actually gets on the phone. But we're introducing quote unquote useful friction from the perspective of a for-profit company. It's why I think there also needs to be a bigger discussion and bigger debate about whether public programs should be administered by for-profit companies, because they truly have different incentive structures than not-for-profits as well as government agencies. Our obligation is really to the beneficiary, to the community. For-profit companies' obligation is to the shareholders, and I think we have to like reckon with this question of how for-profit healthcare has imposed some things that on patient care that we would probably not want for ourselves. So I think there's a big question that we have to contend with there. And then there's of course the question of scale, which is not-for-profits tend to be smaller, but if we're all getting paid the same amount, we may be inadvertently disadvantaging not-for-profit companies vis-a-vis for-profit companies. I know a lot of the policy change that's come out of CMS, both this administration and the last administration, was really directed at some of the bad behaviors of for-profit companies. Those of us who are running not-for-profit companies are collateral damage in all of that, even if we're not doing all the objectionable things that the for-profit companies are doing. So I think there's a bigger question that we have to ask as a society is like, should for-profit companies be administering Medicare and Medicaid? And something we should be, very thoughtful about.
Rachel, can I say one more thing about UM? And these are situations N of one, so take that into account. So I've seen UM applied in the Medicare Advantage space with what I call absence of the larger clinical and social context in which a beneficiary is operating. And trying to push people into home health who actually should be in a skilled nursing facility given their social circumstances. And I think the challenge with the way operates right now is it's sort of one size fits all. It's, an algorithm that's applied universally. And so, I would hope in the future, as I said, that we could better tailor, better customize to, individual circumstances, because I think oftentimes that's probably what the people who are hearing these, requests for overturning a denial are hearing.
All great points. So um, one anecdote I heard yesterday, we're going to do N of one conversations here, is that it was actually interesting. It was somebody was telling me that an MA company that uses a lot of utilization management had offered to gold card a practice or a health system, and so basically no longer do prior auth in that health system because for whatever reason. And the health system actually said, no, we don't want you to do that. We'd rather use prior auth because we're in a two-sided risk contract here, and we don't want to have to manage manage that. And when you do prior auth, it prevents us from having to do that. I'm just wondering, I know, Sachin, that you're an advocate of these two-sided risk arrangements, what role they're playing, and whether or not they can help with the prior authorization burden.
I think they can, because I think you can align, if you're delegating risk to providers, you can align your policies to the practice patterns within that system. And you can build care pathways that are, specific to the group of clinicians operating in that environment. And so they can set their own rules to some extent versus, again, a bureaucrat sitting, 2,000 miles away making those decisions. I think we should be empowering health systems to make their own health systems and risk-bearing medical groups to make the best decisions they can for patients. There obviously have to be guardrails on them as well to make sure that they're not overdoing it and they're not providing substandard care. But again, that's the role of plans, and that can be the role of CMS. But right now, what's happening, I think, is we're taking medicine away and a lot of autonomy away from clinicians. And to Cheryl's point, there are these unique circumstances. I started my MA career at CareMore Health, which was famous for doing really heroic things for patients. in situations where it was needed. We would give people an air conditioner when they were getting dehydrated and admitted for that in the summer months, because it's a lot less expensive to pay for air conditioning than it is to pay for a hospital admission. I think those kinds of interventions kind of went away for a time because they were seen as potentially inducing sale, or they were seen as kickbacks to patients. But there's nothing wrong with a medical group installing a ramp at someone's home, if if they have a fall risk. But those kinds of things, need to be enabled, need to be encouraged. We need to create more entrepreneurialism, and that I think is enabled in these risk delegation arrangements, provided we have the regulatory freedom to actually do those things. So I think, in some ways, we had it more right earlier in the evolution of this program than we do today. And I think we do need to give more freedom and flexibility to clinicians at the point of care to do the right things to take care of patients and populations. And I think that should be a feature of MA, is that, what I call radical common sense gets to actually prevail. So.
That's great. Anything you want to add, Cheryl?
No, I would just plus one on that. I do
Yeah.
think the flexibility in terms of how they can spend their resources has been an area where the plans can innovate to try to provide better care to patients. Absolutely.
Yeah. Okay, well, this has been a great conversation. We only have a few minutes left, but I wanted to end with a question for both of you about if you could set a North Star for what MA should accomplish in the next decade, what goal would you set? And either one, whoever wants to volunteer to go first.
I can go first. I struggled with this question a little bit, Rachel. So instead of a single North Star, I was thinking more of Orion's belt with three stars.
Okay.
Something we haven't talked about today, but I think it is front and center, is reducing choice complexity. We need benefit standardization in this market. It's enormously complicated for beneficiaries to choose, and they're making suboptimal choices. And so that would be one of my stars. I think we have to fix the overpayment problems. And then I would like to see more traction on trying to level the playing field between traditional Medicare and Medicare Advantage.
By reforming traditional Medicare.
That's right.
Okay.
Cheryl, which senator or congressperson are you going to tag with that in this environment? So I want to, I'll make one suggestion, which is Ron Wyden did benefit standardization for MedSup, actually, because MedSup had all the same problems that Medicare Advantage has today, which is we let 1,000 flowers bloom and 1,000 flowers wilt. And I think we have to kind of maybe go to like 12 kinds of flowers, and then competition on quality of flower as opposed to how many different flowers you actually can offer. So I'm a big fan of benefit standardization. I actually think multi-year enrollment is a big deal as well. I think we should be thinking really hard about multi-year enrollment, and you can't do value-based care in 1 year increments. You can't really improve anyone's health, within a 6 month period after they've enrolled in your plan, and then they start shopping for the next plan. That's the system we have today. So I do believe that we have to get out of this notion that there's something magical about 365 days when it comes to health plan enrollment. And I would say probably push it to a 3 or 5 year enrollment, with some beneficiary exceptions that would allow them to get out if under exceptional circumstances. Potentially maybe if the plan's star rating dropped, that could be kind of a reason to get out of a plan. But I do think we need 3 to 5 year enrollment. But I think we have to go back to the future a little bit. I think we have to challenge MA plans like mine to deliver better outcomes at lower costs. That's like the work, and I think we have to be careful not to demand it too quickly, because what you're seeing over the last 3 to 4 years is the rapid change in payments to plans that's leading to plan exits, rapid degradation of benefits, huge turmoil in the markets, market exits. I think you're going to see, this is my hot take. I think you're going to see, one of the big national for-profits either exit or collapse under the weight of Medicare Advantage. I think we've created a very unstable market with some of the policy changes that we've made. And as much as I'd like to see some of those companies, get their act together, they also are a really important part of the fabric of, of how people access care. So we have to be gentle in the move towards the original intent of the program, where we started, which is it should be lower cost of administration for richer benefits for older adults.
Great. Well, those are both great last words from both of you. I want to thank you both for joining me today for this conversation. It's been really fun having you here, and I hope that the goals that you set for MA come true. We have some work to do ahead of us. I want to thank the audience for joining us today and remind everyone that our next regularly scheduled event is not until May, but it will be a good one. It's on Medicaid after HR1, state challenges and policy trade-offs. So I hope that we see you then. And thanks again to Cheryl and Sachin.